I just wanted to share a few things. In addition to being chair of the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health, where the sponsorship of the journal currently lives, I have the great privilege of serving as co-director with Joanne Banach of the Johns Hopkins UPF Public Policy Center. And so I just want to thank everybody for making time to be here. It's really just been so exciting. And I'm hopeful for the end of the day, and I will share why in a moment. And want to just celebrate again this new phase of the journal that explicitly has been lifting up social determinants of health in its name, and will undoubtedly for the next 50 years and beyond push the boundaries and scholarship of how inequalities, power dynamics, structural injustices impact and shape the health and quality of populations worldwide. Through a number of panels today, we heard about time and time again of the importance of policy, of naming social determinants of health, of research needing to push the boundaries and bringing in things like political epidemiology and new frameworks around power and community. We've heard about policies and actions to reduce health inequities. We heard about the role of structural racism. And I hope that you found these comments energizing and thought-provoking. And I say energizing because the work we do is difficult. And I think it's okay to say that. It's okay to say we get frustrated. It's okay to say that it's tiring sometimes. And together in community, I believe that we can continue on the journey to do this work together. Speaking of that work, let me tell you a little bit about the work that we have to do in the US, because we have some challenges. Recently, our US Center for Health, Disease Control and Prevention reported that life expectancy in the United States in 2021 declined for the first time in a number of years and has been at its lowest number since the late 1990s. If you are a male who was born in the US, your life expectancy is now 45th place in the world, behind the European Union. And we know that there's also a disparity by sex. How could a country that is so wealthy, quote unquote, have such poor numbers? We also know that this decline in life expectancy that we've seen has been largely driven by the opioid epidemic, and then also, of course, falling precipitously during the COVID-19 pandemic. The decline in US life expectancy has not been uniform. The data reveal large gaps between communities of color. We see the dramatic impacts on Indigenous Americans, or American Indians and Alaskan Natives. And we also know the important role of community. For example, in Baltimore, in Maryland, where I live, there is a 10-year difference in life expectancy between neighborhoods just a couple of miles apart. You can't tell me that that's due to biology. At the root of these differences by race, ethnicity, geography, gender, are the influences of income, education, employment, transportation access, food access, violence, capitalism, residential segregation, structural racism, and power imbalances, factors that impact how long we live and how well we are living, not only in the US, but also worldwide. As we've discussed today, throughout the day, we need to continue to place greater emphasis on the social, political, and economic contexts in which morbidity and mortality inequalities are produced and reproduced. We need to continue to conduct research as well as engage in knowledge transfer, getting information to decision makers, policymakers, and communities who can do something with the evidence. And I believe, at least in the US, we need to move beyond conducting descriptive studies. If I see another descriptive epidemiologic study about race differences, I'm going to scream, and focus more on research that gets at the mechanisms. Why? And focus on solutions. As a policy person, I believe that policy change is critical to helping address health inequities. And we heard about some policy strategies in the prior panel. We know that governmental and non-governmental policies are critical for health. My own work in health and all policies in the US seeks to partner with non-health sectors to bring health and equity to the forefront. When I think about policies, I also need to comment on the role of courts, and particularly in the US at this time. We know courts don't make policies, but legal decisions impact policy. In the United States, we've seen a rise in the role of the influence of courts and judicial decisions as determinants of health. For example, in 2022, a very conservative US Supreme Court in the landmark case of New York State Rifle and Pistol Association versus Bruin, a case that challenged New York laws regarding concealed carry of firearms, found that it was unconstitutional to ban people from hiding their guns. Let me say that again, carrying a gun in public is a constitutional right based on the decision of the courts. And what is incredibly disappointing about that landmark ruling is that we know that gun violence prevention policies help reduce the epidemic of gun violence that we see in the United States, an epidemic that disproportionately takes the lives of Black and brown people. We've also seen the courts in the US remove the right to access for abortion, remove the right to access for gender affirming care. And more recently and relevant for this conversation today is there are efforts to ban or limit conversation and use of the words like racism, equity, and even the history of Blacks and African Americans in the US. Earlier this week in the great state of Florida, Governor Ron DeSantis signed legislation to defund efforts funding diversity, equity, and inclusion at all public universities in the state, and limit how race can be discussed. DeSantis called these efforts a distraction from the core mission of academia. He and other opponents of diversity training said that equity and inclusion programs reinforce racial divisions and promote quote unquote liberal orthodoxy and is standing for discrimination actually, and has no place in our public institutions. Sadly, Florida is not the only state. We have many other states in the US, including Texas, seems to be on the brink of passing their own bans to ban people who are fighting to promote equity from even using these words. These policies, laws, and court decisions are part of the social determinants of health. It's part of why we're here today. And I know that these policies were developed and implemented by people in power who like to hold on to that power and keep certain groups of people marginalized. And I believe that it is people who will help us get out of the problem that we're in now. I believe in the power of community organizing and voting to change who we put in public office so that they can have the power to shift power and dismantle existing racist and oppressive policies. This, to me, is critical for advancing health equity. Before I wrap with some comments, I want to talk a little bit about language. Today, we've heard some comments about social determinants of health and what do we mean. And I will say in the US, I've been very frustrated by people literally defining social as social and not acknowledging as much the social, economic, structural determinants of health. And this has really been a barrier to moving things forward. And because we have seen now that people are saying, well, let's talk about the political determinants of health separately. Let's talk about the commercial determinants of health separately, as opposed to thinking about all of these together. So my question I just asked is, what does that mean for the field? I don't have a clear answer, but we have to acknowledge that these things are happening. The other part of what's happening is the word determinants. There's a growing pushback in the US on using the word determinants, not determinants, ATS, determinants. These critics are asking, well, what is a determinant? And what does it mean to say that income is a determinant of health? Some people think that that is actually very harmful and suggests that we can't do anything because you're saying your income determines your health and therefore we can't intervene and correct it. And in lieu of saying social determinants, many are now saying social factors or social drivers. Again, I just want us to be aware and to ask, what does that mean for the field as we move forward? I will also say that while I support getting terms right and being clear on what we mean, I hope that we can all agree that whatever we call it, our lives depend on focusing on them. And I don't say that in terms of hyperbole. As Michael Marmot said this morning, the 2008 World Health Organization Commission on Social Determinants of Health report was highly influential in the US. For me, I was a young assistant professor at the time when the report came out, and it helped catalyze my focus on systems and structures and dismantling harms and moving from being described as a health disparity researcher to a health equity researcher. And I'm grateful to many of those who we heard today who laid the foundations for all of us to build on, especially want to call out Carlos and Juan, who we have heard are the co-editors of the journal. So before I wrap up, I want to just share one last thing about hope. I've often heard that hope is not a strategy. And although I agree with this statement, I also know that hope is an essential part of achieving a strategy based on what we believe is possible. I'm incredibly hopeful for the future, especially after being with all of you today. I flew in yesterday from the US. I will fly out tomorrow. It's a short trip for me, and I needed to be here. And although we talked about many challenges today that we need to work through, I invite you to join me in celebrating how far we have come and seeing what's possible for the future. I invite you to join me in having hope and working together, because we know that we can imagine a world that is so much better than the world we live in now. So embrace the possibilities for what we can accomplish, because they are endless. So thank you very much for being here. Thank you for allowing me to close out the conference today. Take care.